Hey everybody, welcome back to Stand By for Tones podcast. With you tonight, you got Isaac and Sam.
What's up, brother? I had to change it up tonight.
You did change it up,
It's all
man.
that whole TikTok rage thing. I love it, man.
Is it?
Yeah, it's the what's up, brother? Special team, special play, special player. Tuesday, Tuesday, Tuesday. It's freaking hilarious, and I love every second that they're taking this kid who, just said that, and now he's going to be probably a multimillionaire.
That's awesome.
Or just coming up with, what's up, brother? Why can't that happen to me?
I don't know. I have no idea, and I did not know that because I'm not on the tickety talk. So
yeah, well, I'm about to not be either if this whole thing goes through and they get rid of it. So
well, I have no focus. So
yeah,
I had to delete things in my life so I could actually be productive.
Yeah,
with anything. So,
oh.
But other than that, how's things?
It's good, man.
That's
I
good.
just got my butt kicked on shift, recovering, and it's gorgeous out, but it's supposed to get shitty again tomorrow, which is
Probably
not my favorite thing in the world. Welcome to the 6th winter of Idaho.
Yeah.
But no, I mean, life's good. Had a lot of really sick patients over the last couple shifts, and we got some good topics today. But what about you? What do you got?
I am just busy. It's the busy season has started, especially for me with not only more calls, trauma season's here a little bit.
Oh, God.
Starting to get some of that stuff, but then also my favorite time of the year as well, rescue season coming up. So
you guys have already had a couple. I mean,
yeah, we've had a few small ones, nothing too major, but looking forward to the rescue season, and then not only just doing calls and stuff like that, but also all the training and all the stuff we got to do. So we've got I think 4 or 5 classes scheduled already.
Sweet, man.
This summer and spring and summer. So yeah, really excited. Going to be gone in the next few weeks, home for a few weeks, gone for a few weeks. So
your wife's going to love you.
Hey, she's going to love just her time alone.
Yep. That money. We all love money.
But no, that's looking forward to that. We love that kind of stuff. I'd love to start doing a rescue talk as well.
You need to get some of your rescue bros over here and, get them in the studio, get them out of their comfort zone and see how that goes. And
no, I think eventually that's the plan. So do some rescue talk.
Stand By for Tones Rescue Division.
That's right. We'll have not only just for rescue people, right, but be good for everybody else as well. So there's plenty of times that, the stuff we do with high angle rope rescue and all that kind of stuff can actually just help you out a ton on the ground. Heck, even getting somebody out of a basement, being able to, tie a few knots and haul somebody up on a backboard or whatever it is can definitely be helpful.
Oh yeah,
save your back. So
I like my back, and I like my career, so I enjoy those little things that I pick up from you guys because I'm not in. To be completely honest, as much as I admire what you guys do, sometimes it's just not my thing. And that's okay. I got plenty of other good things, and I'm sure you guys will suck me into it and let me see the light at some point and
that
make me go over a 486-foot canyon wall for my first time while shitting my britches. I just won't even wear pants on my harness and just let it come out naturally.
No, it'll be fun. You'll like it.
Yeah. No,
or
it's
not.
Yeah.
Or
no.
you'll cry. Either way.
No,
it's
actually,
be a good time for me.
I attended a couple of the trainings when I was in the educator spot and did the nighttime ops down at the Rock Creek Canyon.
Yep.
And that was super fun. Even just observing it and just, kind of just being wouldn't call it oversight, but the guy there with the piece of paper that you had to sign to make sure you got your hours of education for it. But
that's right. I forgot you were there.
Yeah. But I think Chad put me on a hall team just for funsies. And I was just like, okay,
gotcha.
I can get on board with this. Not everything has to.
No, we have plenty of guys that are more than capable of going over the edge, but they'd just rather not, and that's totally fine. So, my favorite system guy, that's what he does. He does systems.
Yeah.
And I'm happy to have him there. So,
That's one of the biggest parts, right? I mean, like,
oh yeah, totally.
Getting it set. I don't know anything about pulleys and ratios and things like that. I mean, like, I get mad enough when I have to change a serpentine belt on the old car, but like, you know.
And see, and that's out of my league. So remember I changed one and then I broke a piece in my vehicle. I don't remember. It was bad. I don't do cars.
We just do humans now.
That's right.
We take care of humans.
That's right.
But yeah, man. What's up? What do we got? We got a long.
I got a good list of stuff for us to go over today, but I think I want to jump back into one of the things we started last time, and that would be the rules of EMS. Yeah. So I want to know. We talked about number one. Number one rule for Sam was treat people with dignity and respect.
Yep.
Dignity and respect, right? Everybody, doesn't matter who you're seeing. It's a bad day for them, so treat kind. My number one rule was don't try to understand crazy, right? Because you'll drive yourself crazy. So we don't have to understand everything.
Yeah.
All right. Number two, what's your number two rule, man?
Oh, man, I was going to make you go first because I'm still working. Yeah, you go first. I'm still working on my number two.
That's easy for me. Number two for me is suction. So suction. It's one of the most important things that we have. It's one of the things that you better make sure the beginning of your shift is ready to go, because I feel like it's probably the only thing that we have that when we need it right now.
Yeah. No, 100%. And I mean, like, and that just comes down to what we preach the most when it comes down to our airway management is that follow through suctioning, the salad technique, like getting people to understand that they need to have suction out. It's cause for almost a good 90% of missed innovations on the first pass success rate, 100%. If not more.
100%. I absolutely agree. I think the number one reason that you're failing airway is because you didn't have suction on and going.
Yep. And you can't see it. Because, I mean, most of the time, there's going to be that subset of population where positioning and Craig pressure and all these things just doesn't work. And, it comes down to technique and things like that. But those are, I don't want to say rare, but I mean, like, it's part of the game. But I mean, like, the majority of the failed airways are because of suctioning.
Yep.
And, after reading hundreds of innovation charts over the last few years, like, you get a second pass success. It's like, what'd you guys add? Oh, we added suction.
Yeah.
Oh, wonderful. I'm so glad. Like, this is good. So, and that's not a dig on anything, but I mean, like, because we've all been there. Like,
correct.
I mean, I can't tell you how long it took me to get used to. I mean, like, when we first got the King Visions and we're really rolling that out on how important that was and, how foreign it felt to have a suction catheter in your hands at all times.
Yep, that's what I go in with is the suction. That's what I open with.
Yep.
So suction catheter help open the mouth.
Yeah,
and that's the first thing in. So before my blade even goes in, that's the first thing, suction.
Yeah, and it's a great tool to displace those odd tissues, like help move that tongue out of the way. You can put it posteriorly in the esophagus and just do passive OG suctioning. Like, there's so many cool things about it.
Yeah, one of my favorite airways that I did, one of the most difficult ones was, that suction was key, not only continuing to get the blood out of there, but literally just because of how messed up the airway in the face was, had that suction literally pulled as hard as I could to one side until I had somebody take over, grab it, like continue to pull more and just keeping tissue out of my way. So that suction is important.
Yes. My number two. I'm struggling with these recently for some reason. I don't know why. I've got a bunch of things that run through my head, whether it's silly or not. But I think really, I'm going to go back to my kind of the patient assessment side of things is embodying the, how do I want to put this? The art of talking to a patient. Because the conversational assessment, because we get so focused on, like, we want to get our sample, we want to get our OPQRST, we want to get our AVPU, and all these random little acronyms in our assessment when we can do all of that with holding a normal conversation with a patient.
Correct.
And, it takes the stress out of the environment if we can just have a conversation like you walk in and be like, hey, my name's Sam. I'm the paramedic that's going to be taking care of you. And sorry, we have to meet under these circumstances, but can you tell me a little bit about what's going on today? And then you kind of tailor into adding family and talking about their day and asking about their pets, and you get a lot of responsiveness and all these other things. So I think my biggest thing is, getting comfortable to have that, the conversational assessment more than anything, because it's hard. It takes time to learn.
It does.
And how to fit those in. I mean, like, because there's times where I go on a chest pain patient, it's like, I'll be, just talking to them and just be like, so might be a minute or two later that we're talking, and just be like, can you tell me about what that pain is that you're feeling in chest? When did this all start? Like, you got to build that rapport with people to have them feel comfortable with you.
Yeah. Talk with your patient. One of my favorite things when I was doing FTO stuff. So have new medics and training them, and I always have to force myself to stand back because I'm a control freak. So I would always just force myself to stand back and just listen, and then also just talk to some bystanders as well, or family members and stuff like that. And I usually came out of the house knowing more than everyone else because I would just talk to people and got the full story versus just whatever my, straight up physical and talk assessment, OPQRST stuff, showed me. So I like that. Number 2, talk to people.
Yep. The conversational assessment, and if they're going to talk, don't interrupt them, even if it's long-winded. Like, I'm a long-winded talker. Like, let's be honest. You can summarize what I'm going to say in a sentence. It takes me 10 sentences. But I mean, like, if they're going to talk, just let them talk. Like, it's okay.
Yeah, it is. It is. And hey, if they're sitting there talking your ear off, they're probably stable. So there you go.
Ooh, that'll be the next one. We'll add golden rules for the next one. Will be the kind of the art of the 30-second assessment on how to nail that. That's always a good one.
That is a good one. That is a good one. So, well, I think we will jump into a topic today, which I think our first one we're going to talk about is abdominal pain.
Yeah. I guess where this comes from, man, is that I am struggling writing our ALS content and trying to, break it out of the realms of just full critical care and breaking it down to EMS. So I'm going to give it a shot today.
Yeah. I like it.
And so the topic is AAAs, but I kind of want to break it down a little bit more into abdominal pain and kind of go with the abdominal pain, ALS or BLS, and how do we differentiate that? Because that's really hard. Gotcha. Because non-specific abdominal pain plagues the ERs.
Oh, it does.
Nationwide.
Totally.
Right? Like, non-specific abdominal pain. It's like, okay, there's a lot of things going on in there, but we can't tell what's happening.
Correct.
And like, then you get people having these, open abdominal surgeries and doing all that stuff. But off that case, like, I want to get your thoughts on what in your mind drives an ALS versus BLS abdominal pain.
Ooh, that's a mean question. I like it.
I know. It's a question that has plagued our industry for years, man. Like,
no, it is good. With that assessment, right? Mm-hmm. I mean, comes vitals, I think. So anytime I have somebody who's got abdominal pain, you got to be looking at their vital signs as well. Yeah. Right. So tachycardias, hypotension, anything like that. Obvious hypotension, that's going to make it a little easier. Mm-hmm. But look at that heart rate as well. Obviously pain can increase your heart rate, but typically it doesn't bring it up to 130. Yeah. So got to look at those things. Touch that belly, right? Feel it. Make sure you don't have ascites. Feel where that pain is. If you're pushing, feeling for that big pulsatile mass. Yeah. Right.
Oh yeah.
You may feel.
We're gonna get there.
But then for me, when I'm talking about a AAA, anytime I have abdominal pain, just like we all should, that's something we should be ruling out. Right. Yeah. That's one of the things. Just like chest pain, you're gonna rule out if they're having cardiac type chest pain. Same thing with abdominal pain. You want to rule out if they're having AAA type pain. Yeah. So with that, I'm going to, describe that pain. And then I want to know, does it radiate anywhere? Mm-hmm. Right? If it radiates to their back, okay.
That's scary.
Ding, right?
It's scary.
Light bulbs are starting to go off a little bit. Okay. And if it radiates to their back, I want to know, does that radiate down their back or does that radiate towards their legs at all? Mm-hmm. Right? Because if I have abdominal pain that's radiating to their back and down to their legs, I'm calling it a AAA. Yeah. Right. Unless it's a young female, then okay, maybe I'm thinking this is a
ectopic
or something like that.
Pregnancy related something.
Correct.
Lady bits part.
Lady bits. That's right. Could be a lady bits issue. But no, I definitely want to know those questions there.
Yeah.
Does it radiate? And if it does, this is going down your back or down towards your legs.
Mm-hmm. I think a lot of it comes down to, as well, is like, what are they describing their pain as?
Correct.
I mean, like they get that AAA, they get that ripping or tearing sensation. It'll sometimes refer back behind their shoulder blades. And, it just kind of goes, I mean, it also depends on how high and how low that AAA really is. But like that, just like that burning sensation in your belly, like those are hard. Like, oh, I've got a little bit of a ditzel around my...
A ditzel?
Yeah, a little ditzel. It's a medical term. Look it up one of these days.
I'm going to have to look that
up.
Like
a little, I think it means little injury. I learned that from one of our docs in the ER because he was just like, oh, you brought me another patient with a little ditzel. And I'm just like, I don't know what that's supposed to mean.
I don't know what their ditzel look like.
But they got a little ditzel in their belly or something like that. But I mean, like, you've got your appendix, you got your spleen, you've got your gallbladder, you've got all of your mesentery. Like, there's so many things that can go into it, and it's really hard to differentiate that. But, I think the biggest thing too is like what you talked about is our looking at our vital signs, looking at our skin color condition. One of the big rules that I kind of go off with heart rate. I mean, like I'm a huge nerd for shock index.
Yes.
As per usual, but go ahead. What'd you find?
I found a few things.
Oh, okay.
So one of them was just the ditzel, meaning very little.
Oh, okay.
And then the other one I found, ditzel, is an informal term widely used by radiologists to refer to indeterminate small pulmonary nodules.
Oh, okay.
I've seen a few of those on my Google search here.
Yep.
So I don't know. So little or nodule. I don't know.
Yeah. Well, it's a ditzel.
It's a ditzel.
I'm gonna call it a ditzel till somebody proves me wrong.
It's a real word. I like it.
Yep. So, anyways, I'm a huge nerd for the shock index, right?
Yes.
That systolic greater than blood pressure. If it's greater than 1, they're, having a, some form of shock state, or I guess not.
So
shock.
say that again. So
if their heart rate's greater than their systolic, and that if they're divided together and it's greater than 1,
yes,
then we're looking at a significant shock state of some sort.
Correct.
But that's not always the case when it comes down to these, because we can have tachycardias at 130 with a blood pressure of 135 still.
Yep.
Like, it doesn't really apply all the time. But one of the other rules that I think about too is like if you take 220 minus their age in years, that gives you your very tippy top of their physiologic ability to get their heart rate that high.
Correct.
Like, I'm 32 years old. So what's that put me at? Like 180? No, math is hard. 198?
Yeah.
So, no, 188. Yeah, 188. Yeah. Math is hard. So, like, I know that I can physiologically get my heart rate up to 188 either on my own or, by trauma or something like that without it being like an electrical abnormality like an SVT or a WPW. So
you can definitely work out hard enough to get your heart rate up to 188 or have enough stress in your life to get your heart rate up to that high.
Yeah.
Right. But if you're going higher than that, then typically that's some sort of dysrhythmia.
Yeah. And so those are kind of those key indicators that I clue into, like when it comes down to abdominal pain and like how high is my heart rate? Like, is this going to be arrhythmia related, or is this pain related or shock related? So there's so many ways I can take that. We could go off on a tangent forever, but I want to talk about AAA a little bit because I had a really crazy case. An older gentleman and came in because he thought he had kidney stones, and it's that referred, that lower abdominal kind of going down the back, pointing towards their leg pain, kind of wrapping around the side. Yeah. Comes in, not only does he have kidney stones, but he's got 2 16-centimeter wide abdominal aortic aneurysms. And that raised the cackles on my neck because I'm talking to my partner, like, we have to rate control. We have to, get their blood pressure under control. Like, there are so many things, but we got to see what the hospital is doing beforehand. Yeah. And not only did he have a tachycardia, he was hypertensive, but he also got 1 dose of pain control and it dumped his blood pressure to 80 on once. But then his white count came back at 24,000. So he's septic on top of this from his probably kidney stones and, trying to fight off whatever's happening with his, burst casing of a hot dog aorta that he's got going on. And I mean, like, I just think about it. I think of the AAA of like a freshly grilled bratwurst that's about to explode. Like, I mean, like, it can happen like that. You poke it just wrong and it's going to explode. And then all the delightfulness inside is gone. Right?
That's a great analogy.
Like, it's all gone. I lived through food. I weighed 400 pounds at one point in my life for a reason. Right. But I mean, like, this guy, we get in there, gonna pick him up from CT. He was getting his CTA as we were walking in the door, and his heart rate's 130, blood pressure's 132 systolic. Like, we have room. Like, yes, we need to drop him. And some of the biggest points that comes across when it comes down to the AAA is the number one thing we got to do is rate control. Yep. Like, aggressively treat that rate. Try and get them between to the 50s and 60s as best you can, because the thing that we're trying to avoid is those shearing forces. Like, every time that heartbeat hits that side of that wall of that aorta with a good blood pressure, I mean, it's just pounding away. Like, it is.
Correct.
It's like a chisel, basically. Yep. So we're going to do, the first thing is going to be our rate reduction. Then we're going to go with, pain control and, blood pressure control. And usually those will kind of come sequential with, kind of as a package with each other, because like, you get their pain under control, their blood pressure is going to drop, and then you can start adding.
Their heart rate goes down as well.
Yeah. Yep. Like, you're just overall reduction of cardiac output.
Yeah.
So we're going to kind of attack all those three things at the very beginning. We gave him 10 of labetalol, just to start off. That's where our protocol starts.
Yep.
And, we dropped his heart rate by almost 40 points with just that 10. And I was just like, okay, this is going to be good. Yeah. Like, give him another 10, comes down another 10. I mean, we only had a 7-minute interfacility response time from one hospital to another. So to get him down almost 40, 50, beats a minute over that time frame was a good goal on our end. Good. Unfortunately, we know that AAAs are very devastating to many people in these situations. So, I mean, like, we have to kind of keep that in the back of our minds and how we're talking to our patient, like helping them understand that we're going to do the best that we can. But we don't want you to push, because if you feel like you're going to have to poop and you push too hard, you're going to pop it, and we're going to be coding you, and it's not going to go well.
Just like a pregnant lady, no pushy.
Yeah, no pushing. Like, if they say, I'm going to look at the camera for this one. If your AAA patient says that they have to poop, you tell them no. Okay, that's just the nuts and bolts of it. Like, the more they tense up their abdominal wall, the more the pressure they're going to put on it, and the more they're going to pop it like a balloon or a bratwurst casing in this case. So, there's so many rules to it. And what do we do if the AAA ruptures? There's not much. I mean,
CPR.
So,
no, it's devastating. And I think right now it's still 50-50.
Yeah.
As far as survival rates go for somebody who's, had an actual dissection.
Yeah.
And there's always, we call it people who are dissecting, and then doctors always say, no, they're not dissecting. They're already dissected. Like, I don't know.
I think that comes down. Yeah. That'll come down to like the layers of the aorta.
Correct.
Technically.
But yeah, it's low success rate, as far as, or survival rate, I guess. But no, the rate control, absolutely great. Obviously, just like you said, you followed your protocols.
Yeah.
Hopefully your system has protocols for that as well.
Yeah.
If they don't, then just
they should
ask the docs what they want.
Yeah.
And if it's, the ER doc doesn't know, ask the surgeon that we're going to deliver this guy to what he wants.
Yeah.
Right.
Yeah. And then just some of the, the background stuff of like the antihypertensives, like, we're lucky. We carry nicardipine, we got labetalol, we've got all these kind of different options. But kind of in my realm, I'm going to hit them with that beta blocker first for that rate control, and then go something more direct antihypertensive like nicardipine afterwards. And a lot of ground agencies aren't going to have that, but the biggest thing is the recognition of it. So that tearing abdominal pain, that pain goes from their belly to their feet. And then this was the first time in almost 15 years that I've had a AAA that I could actually feel. Like this, this guy's AAA went from his subcostal region just underneath his rib cage down to his iliac crest, or basically his iliac bifurcation.
Wow.
It was massive.
That's big.
I mean, like, it involved his mesenteric arteries, his renal arteries, right. His common carotid. I mean, like, just came off the base of the common carotids. Wow. And like, I mean, it was impressive. Oh, and then the other thing we need to talk about too is the pressure differences in arms. I mean, like, that's correct. Always a huge thing to look for as well.
So when we have some of those higher AA's, I guess, aortic aneurysms, remember that circulation for your left side of your arms, right? For your left arm, your left side, it's going to come farther than the right side is. So you may have lower pressures on the left than you do on the right. Not always. It's pretty rare, but I'm trying to remember. I remember looking at a chart the other day for percentages. Oh, it was when I made a PowerPoint. Mm-hmm. I can't remember what it said in the classifications for the abdominal for the aneurysm.
Yeah, for the aneurysm.
For the aneurysms. And I don't remember what the statistics were on that.
It's not good.
I'll have to look it up again.
Yeah. But then the other thing, too, is just checking your pulses in your extremities, too. I mean, just like...
Yeah, and that's another good one, too, is for your
legs.
You can check those feet.
Yep.
Right? You can check the legs as well and see if, like, again, you have good pressures, or just look at what the color is.
Yeah.
In those lower extremities as well. So...
Yeah, there's so much that really goes into it that, is more just like we need to hurry up and get going. And, while doing our medical management, because I mean, like, we were going direct to OR, and the longer we wait, the longer that aorta is going to be leaking and the less chance of survivability that we have. And
they get real sick.
Yeah.
Too. It's that was a big one that you took there, but wait till it was awesome that you got to use labetalol and is that what you used?
Yeah.
Sorry. And start treating that heart rate, but just wait till you have the ones where have two pressors going as well.
Yeah.
Right.
And that's a really good point to make too, because people get confused pretty frequently on like which blood pressure do we treat? Like if they have a left arm blood pressure that's, 40 systolic and they've got a right arm blood pressure that's 180, like which blood pressure do you treat? And you're always going to want to treat your higher one.
Yeah.
Never treat the lower one because,
it's a compromised circulation.
It's a compromise. Yeah. So, I mean, like, you just kind of got to think about it in the way of like, we need to know where this is starting, this injury of the aorta is starting, and, what blood pressure to treat. And we're always just going to treat the higher one at that point because, if it's 180 on one side, it's probably 180 everywhere else, and you're just getting that compromised circulation.
Correct.
But this guy, I mean, like, he was a pretty skinny guy, and, being able to feel, I barely put my hand on his abdomen, and I just could feel it just hit my hand at like 130 beats a minute. I'm just like, that made the hair on the back of my neck stand straight up.
Oh yeah.
And, I mean, I hope people take away from this that, even after 15 years that we still get that hackles on the back of the neck. Like this could go really south really fast.
Yes, it could.
Yes. And please don't walk your AAA patients because if you diagnose that, that's the last thing we want to do. You're just going to create more stress. You're going to get dependent pooling down in the abdomen. Like there's going to be so many things that can happen and, increased pressures and then just movement in general is no bueno. So.
Yeah, I do remember walking one AAA patient. I didn't know he had a AAA to begin with. I knew he was sick kind of looking, but he lived in this really dark shack and it was like squishy floor.
Ugh.
And I wasn't doing anything.
No, you don't kneel on
and
that.
I wasn't doing anything in that house. I remember telling my partner, do not put the bag down.
Yeah.
Like, get up, let's go.
That's one of those ones where you step and the bed bugs scurry away from your feet.
I didn't even think they wanted to live there. It was that bad. So no, I remember getting him out, and then as soon as we got him outside and then the ambulance was like, ooh, you don't look very good.
Yeah.
And it was like, okay, figured out, hey, he's got a AAA.
Yeah.
Like,
it is recognizable in the field.
It is. Yeah.
And, I think that's one of the big things that is lost in our industry sometimes is the art of just not only talking to patients, but feeling comfortable touching them, even if they're ewy to touch. Like I kneeled in like the biggest puddle of pee on accident yesterday. And yes, it sucked. And my flight suit was wet, but I got over it. But you can't be afraid to like get hands on with your patients. And
and we, like I said, after getting them out of the squish floors, then it was like, okay, get to work.
Yeah. It's game on.
It's like, oh man, you look he looked like crap, and then figure out, okay, he's got a AAA.
Yeah.
And then it was nice to be able to call that in, and sure enough, that's what he had. For me, I always get AAAs and runs of 3s as well. So good luck with that.
Oh, thank you. I don't like that.
Almost every time. I've had about 9 of them, and it was like 3, 3, and 3. It's like, that I recognize for sure. You know, not just something that I've taken interfacility, I guess, but in the field wise.
Yeah, I'll have to. I'm going to keep my awareness up because my patients have not been the easiest as of late. So lots of neuro though. I've had a lot of neuro, but on the kind of wrapping up the AAA recognition. I mean, it's hard, but it's doable.
It is.
And
it's totally doable.
As an EMS provider, like boots on the ground in an ambulance, the biggest thing I want them to focus on is, you know, if they recognize it and their heart rate's, you know, 100 or greater, bring that heart rate down. Start targeting that 50 to 60 a minute. And that's going to be really limited by their protocols, right? Like not everybody's going to have, you know, labetalol or metoprolol or something that will be that will induce a safe heart rate for these patients. And then, you know, really targeting that blood pressure. I think a good systolic range is about that 110 systolic, you know, between 100 and 110, because we're trying to reduce that overall cardiac output, reduce the strain on the aorta, because they are repairable. There are ones that are very survivable. Totally. But if we don't take the time, I mean, like this one had been progressing for 7 days of this pain. I mean, it's great that he survived the 7 days, but I mean, like, it's just one of those things. Like, if we get it early, they are treatable, survivable. So really key in on some of those good indicators. And I think it'll go good. Not saying that they always go great, but you know, I take away the small victories of providing the best care that I can
for sure, and
being able to see it through.
Yeah, absolutely. You're going to do the best you can. You don't always have results over the outcome, but you know, early recognition, especially in the field, figuring that stuff out, can just progress stuff a lot quicker. Yeah. You know, if I can show up to the ER with a doc standing in the room with an ultrasound ready to go.
Heck yeah.
Like, I did my job.
Yep. So. I mean, and we can talk about pre-hospital ultrasound all day long. This is one where I would not like I think pre-hospital ultrasound is a great thing, and why the docs, you know, there's some docs that push it and all these things, but like I could definitely see myself in that situation if we had pre-hospital ultrasound, trying to dick around with my ultrasound to see my shotgun sign and see the size of my aorta and, you know, trying to chase everything down and wasting my time at that point. Yeah. And, you know, that's my little plug there, is it's a tool.
I agree. I think, and we can talk a little bit about it too. I think the ultrasound is a great tool to use, but it's something that you can't get distracted with. Yeah. Right.
That is a in-flight procedure in my mind.
You've done your stuff. You can use it now to, again, reevaluate things, see how their fluid status is, right? Now that he's still got soft blood pressures. I've given a unit of blood, like let me look at his liver and see what I can see. Yep. You know, is he bleeding there? Do a fast, that kind of stuff. Yeah.
Check the IVC, do your due diligence of finding out where the fluid or blood is going. Yeah. But it is a tool. I mean, and it just confirms the suspicion of what we already should know. Correct. There's blood not outside the body, so it's got to be inside the body somewhere.
Inside. Yep.
So, yeah, that's the AAA talk in a nutshell for right now.
No, AAA is good. I've had, like I said, plenty of them. One of the last ones I took, we were on a couple pressers, and we
that scares me, man.
Oh yeah, that was fun. Because we went in going like, okay, cool, we're gonna, you know, get their heart rate down and their blood pressure down and get there, and it's like, oh, okay, we're gonna get their heart rate hopefully somewhat normal and try to keep their blood pressure, you know, above 50. So but remember with that, either AAA or AA, if it's higher up as well, is that can migrate down. It can go into the heart as well, so you can get some of that cardiac effusion. Yeah. What do I want to say? Is that right?
Cardiac tamponade.
Thank you. Yes. So you can get some of that. You can get a cardiac tamponade with that as well. Yep. Right. And if that starts getting big, you're going to see those pulse pressures start coming together. And then if you're having bad pressures with that, the only way we can really treat those is fluid and more fluid and more fluid. You got to give them lots of fluid. So.
Yeah. And, you know, that really kind of, you know, brought up another point is like, there are these classifications of AAA, the DeBakey scale.
That's what I was talking about. Thank you.
Yep. So it's the DeBakey scale, and it ranges. There's two forms. So I gotta refresh myself. So you'll have your proximal and your distal DeBakey scales, and then it'll be like a 1, 2, or 3.
Yes.
And basically the higher it's a 1, a 2, a 3, a 3A, and 3B. So the 1A is the ascending aorta, plus or minus the descending aortic arch. The 2 is the ascending aorta only. 3 is the descending aorta. 3A is limited to the descending thoracic aorta, and 3B is extending below the diaphragm.
Gotcha.
So basically, my patient had a 1 through 3B, it sounds like. And, like, if it's involving that much arterial vasculature coming off of it, like, not a good day.
What was the percentage? Does it have it on there?
Of survivability rate? Or
just for frequency as far as what's most common?
Let me look that up.
That'd be, because that's what I was trying to remember.
This is going to take me a minute to find.
Yeah, okay. We don't have to do it. I was just curious what was the most common.
Yeah, this is going to take me some time to figure out. So
that's okay.
I won't waste our time on that, but
no worries. Another thing about those higher aneurysms as well is you may see patients that have stroke symptoms as well.
Yeah.
Right. And they may come and go depending on position. Right. If you sit them up and now they start showing stroke symptoms, and lay them back down and they go away, or vice versa. You lay them flat and maybe they have a stroke symptom kind of stuff going on, and sit them back up, it goes away. You can get that just with that tearing. All right. And it's starting to throw clots in there. Yep. So
it's called a stuttering stroke.
There you go. Stuttering stroke.
It comes and it goes. Very common to see in carotid artery injuries.
Yep.
This is the first time I saw that was a carotid artery tear.
Gotcha.
Yeah. Started building up all those little clots, and it freaked me out, man. Like I went to go pick this guy up and full blown stroke, and then 5 minutes later, completely fine, and then 5 minutes later, full blown stroke. I call one of our MAOCs, and I was just like, dude, I do not know what's going on. 1 second he's having a stroke, and 1 second he's not. And he's just like, that's called a stuttering stroke, and you better get your butt here like right now. And like I was like, oh, okay, thank you.
Yep.
So I will never forget that, Captain.
Yeah. So I remember, taking one out we're on a stroke standby, and then it turns into a, aortic aneurysm standby, and then we leave, and then we get the call on the radio. Hey, by the way, it's already dissected into into the heart, so watch for that.
Yeah. Godspeed.
Thanks for that.
Yeah.
Some things are better just left
unsaid.
Kept to yourself.
Yeah.
Thanks for that.
So, but yeah, I think that wraps up AAA in a nutshell.
It does. I think, again, it is recognizable in the field.
Yeah.
Ask your questions, just like Sam's rule number 2. Talk to your patient, figure that stuff out, do a good assessment. And again, I always ask if that radiates to your back, if it goes down towards your legs, right? Your flag should be up, and you should be ready for AAA and be calling that in.
Yeah.
Don't be afraid. If you recognize that stuff, and that's another thing I would say too, is if you're recognizing something, don't be afraid to call it. Yeah. Call it in, even if the docs give you crap for it.
I'd rather have a high instance of overactivation and, concern than an underactivation. Yep. Kind of that old adage of it, if it walks like a duck, quacks like a duck, it has a high potential of being a duck.
It's probably a chicken.
It could be a chicken. It could be a chicken. Chickens are weird, man.
I had one scare the crap out of me today, so I have chickens. And I went out to go start dinner, and I'd been noticed one kept getting out. I'm like, I don't know what's going. I didn't know where they were getting out, and I just walk out on the deck and just flap, 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 flap. Just it freaked out as it flew through the little hole in the fence. It scared the crap out of me. But not that, that has anything to do with anything. But it was funny.
At least you weren't having a AAA. You could have shit yourself and ruptured.
I pretty much did. It scared the crap out of me. Stupid chicken.
Oh man. So the next one's kind of fun for us.
Oh, what's next?
What's next is we had someone reach out to us after having a head-on motor vehicle collision. Man, words are hard some days. Head-on motor vehicle collision, bilateral femur fractures, and what is midshaft, and what does midshaft mean? And we couldn't answer that.
I know. We had to look it up and call phone a friend.
Yeah, we called multiple physicians.
Yes, we did.
Talked to multiple medical directors, a couple trauma docs, and things like that, and trying to figure out what midshaft means.
Yes. So basically, the biggest question as far as midshaft is, does that mean it's right in the middle of the femur, or, do I have some room to play?
Yeah. And, this provider was, getting kind of some questions on like, why didn't you put a KTD on this other femur fracture?
Yeah.
And, it was a little bit more distal, about 3 inches above the knee area, but in the diaphysis of the femur itself. Like,
correct.
There was no knee involvement. There was no ankle involvement. There was no hip involvement. Like, are we still able to put it there? And
the answer is
yes.
Yes.
Absolutely.
Yes, we are.
So after we talked to multiple physicians, they kind of all came down to is like, as long as it does not involve, they called it subepicondylar region. So the top of your femur down all the way to where it starts to Y out or get fatter at the bottom in the distal end of the femur. As long as it falls in between those two areas, and you don't have ankle involvement, you don't have knee involvement or hip involvement, it can be considered for a traction device.
Yes, it can.
And, that's kind of one of those things that, we do a poor job of teaching at, because 15 years later, I would have been like, it's a little low.
And I've definitely put them on when it's not right in the middle, but
yeah,
no, it's a good question to ask is, what does midshaft mean? So, and basically we're just talking about, the actual femur itself. So before it starts to widen out, obviously if it's right at the knee, we're not going to do that, but, or same thing with your hip, right?
You got that high femur fracture.
It starts where that starts to widen out again at the top, right? You're looking more, it's more of like a hip fracture than a femur fracture. So,
no. And I thought that was a great question, more or less, because, I'm sure there's going to be somebody out there that's sitting there that's going, I wish I would have. I'm glad they answered that for us.
And it was like, for me, I can guarantee the ones that I've done that were lower was because the other one was not. And I could see how shortened it was compared to, that other leg. So when you have bilateral femur fractures, one's obviously in the middle.
Yep. You don't know where it is. Yeah.
So that's like, well, shoot, I can't even compare to that one. So
exactly. Because
great question.
Especially when you get in that, like you said, the displaced femur fracture, and having 2 displaced femur fractures makes it very hard to determine midshaft.
It does. It makes it harder to splint too.
Yep.
Right. Because typically I'm using the other leg as my guide for
how long it's supposed to be,
how far I'm pulling my traction.
Yeah.
Right. Another tip with that, guys, if you don't know, right, when you are setting a femur, you're using a traction splint, is don't use the traction device itself to pull traction.
Yes.
Right. Grab that ankle, pull that leg. Don't do it right away.
Yeah.
Okay.
Make sure it's set up.
Don't move. Don't start pulling traction until everything's set up. You have the traction device on. You're ready to set that. Right. You've measured it out.
Yep.
All your stuff's ready. Now you're going to have somebody pull manual traction. Right. Pull it. You'll feel it. You'll feel it go. You'll feel it go back in as well. Yeah. A lot of times you'll feel that realign and get that to the right length, and then you want to tighten that splint up.
Yep. And most of the times your patients are going to go from an agonizing 10 out of 10 pain to an I feel a little bit better.
They'll go from a scream to a really big scream to
I feel better.
Yes.
Yep.
For sure.
These snozberries taste like snozberries. And like that. Really what that came out of right there, and what that comes down to, is our old National Registry check sheets, right? Like, it was pull manual traction first while you set up. After you had everything set up, so what I do is I have my ankle hitch on first, and I have whoever's going to pull with that ankle hitch, so I don't have to try and work that strap around their hand. Yeah. So make sure that ankle hitch is on first, because then the last thing you want to have to do is let go to get that strap on.
Yeah.
yeah. But that also brings up, I wonder what's going to happen now that the National Registry is getting rid of the practical examinations for us.
I'm okay with it.
I'm very okay with it, as long as the schools are doing their due diligence in doing their skills verification.
Yes. Do your skills, and I don't mind that kind of checklist and how you teach it and go through it and make people practice it. Mm-hmm. Just like with, I think, like with your IVs and your innovations and all your stuff, should be checked off on that.
100%.
Do it multiple times, right? It's just like anything, because when you're stressed out in a big trauma and you're worrying about the femur and everything else, I mean, you're going to resort back to muscle memory and to just that basic core of your learning. So, no, it is super important to make sure that that's still being done. But no, I'm totally okay with not doing that in registry anymore, because it was just something else to learn and forget.
Yeah. I mean, all it did was it built good and bad habits.
Yes.
So just as long as people are practicing and getting the hands on that skill is what's going to, make it or break it.
Yeah.
It's going to be a huge change for us coming down the line, because the paramedic practical registry goes away. I think it's July.
Is it?
Something like that. They roll out the new adaptive test, and I think it stops in July.
Oh, cool.
So
I haven't done the paramedic test in a long time.
Yeah, I don't know if I'm going to go do this new one.
I don't know either.
Yeah, the fact that, they have to put the importance of how to treat things in, sequential order.
Oh, really?
That would be really hard. Yeah, because the new written test is all about, your thought process. So, they'll give you a multi-step scenario base where it has, all of these right answers, and then you have to put them out in sequential order on how you want to go about treating said patient. It'll be BSI safe and every breathing circulation. Then it'll probably throw in a needle thoracentesis and vital signs and all these other things. It's very NCLEX-y, which is good because it's starting to align more. Maybe that's a good thing for us.
Maybe. I hate that.
I hate it too.
That style of question. I hate that style.
Yeah, and it's going to be really hard. I'm really curious to see how success rates are going to go, especially for some of these big programs that do really well. And how that's going to change it.
I imagine they'll continue to do well. I think the good programs do good for a reason.
Oh,
but, no, that's interesting. I actually didn't know that. So, actually, I remember you giving me a question.
Yeah, I think we watched one of the other paramedic educators talking about it, and
I remember you having me do a quiz or something, and it pissed me off. I remember that.
Yeah,
but no, that's interesting.
Yeah. And we'll see how partial credit works out. If you get 3 out of 4 in that section, right? Are they going to give partial credit? They're going to give you a complete wrong answer. They got a lot to figure out between now and then.
No, that is a good question. So I think as soon as those answers come out, we will make sure that we share that. So.
Yeah, because it's changing.
It's
evolving, and it's good. It is a good thing for us.
There's a good thing in change, right?
Yeah.
So as much as we may not like it, sometimes change is great. So,
we sit there, we think about all of the things that the little luxuries that we don't have that some of our nursing counterparts get.
Oh yeah.
And it's maybe this is what they had to go through to get to where they are now, and we're just that many years behind.
Finally catching up.
And we're finally catching up. So it'll be good. I'm excited to see how that goes. I probably won't go sit for it just for the fact that I don't want that.
Right.
Maybe.
I haven't done that. I've redone the flight medic one. Mm-hmm. I prefer to research that way.
Yeah.
And then just now with us, I think our goal is having us take it.
Yep. Every couple of years.
Multiple times. Just so we stay fresh on our stuff, so we can make sure education is up to date and we're hitting the right points. Yeah. But
what if the IBSC changes it to that step-by-step process? That'd be hard.
Fight somebody.
I spend a lot of time writing test questions, and I'm still not great at it, and I would be so miserable if I had to go in and rewrite everything again. But femur fractures in a nutshell, everybody. That's it was a really good thought-provoking question that took, just one that I had to write back and say, I don't know, but I will find out. I don't know. I don't know.
No, so which is, I would say, bring us some more of those questions, because we love it.
Yep.
Anytime we can learn, it's great, and we're happy to share what we find out or what we know. So
and
if you have a question,
a lot of those questions are ones that I'm not just going to sit down and be like, I wonder what midshaft really actually means, and type it in and then have it blow up into this huge thing. So I like that, these thought-provoking ones. But
Yeah. Speaking of thought-provoking, let's talk about our next topic. And one of the things that you brought up was a video.
Yes.
That was getting all sorts of controversy.
Yes. There's all sorts of controversy when it comes down to, everything. Like everything medical, to be
for sure
more specific. Like even some of the TikTok videos or Facebook reels that we put out, like there's controversy in it. Like I put one out and, it was all about like the fire paramedic versus the street paramedic and how their roles, I just made a snippet of that and it was like, got like 50 comments. And then over the course of, 3 hours, all of those comments got deleted by the commenter. And I'm just like, you guys are wusses. Like I put this out there.
That's funny.
Like, and you guys all deleted your comments.
I didn't even see that one.
Yeah, it was funny, man. Like I was having a blast reading the comments because there was a lot of people that agreed and some people that disagreed. It's just part of what we do.
Yeah.
And, it's human nature to be able to disagree with people.
Yeah.
And, I was just like, watching them all roll in and then all of them get deleted. I was just like, this is fun.
It is fun. And and it's good to have those conversations.
Yeah.
Right? Have the conversation. And you don't have to be right. You don't have to be wrong. It's just come into those things with an open mind, in my opinion. Is I love hearing opinions, right? And I like, okay, maybe I'll think about that for a day or two, right? Or do my research and see, because if I just don't know and see what the other side says, and I like to come up with my own opinion, so I don't just that's me, I don't just follow the crowd. I want to know what
I think it is really good to be able to professionally disagree with people.
Yeah, for sure.
And but you also, when you professionally disagree with somebody, have to have the reasoning why you're disagreeing with them.
Correct. But
having a professional disagreement isn't okay. It's an okay thing to be able to do.
It is okay.
Like, I have no problem talking to you or some of our other coworkers, and like we can have disagreements all day long, but it doesn't hurt our friendship. It's all about work and random things that we can, and it's just one of those things that people get uncomfortable having.
Oh yeah, conversation's hard. All right, communication is one of the most important aspects of our job, and it's always the first thing to break down.
Yeah.
So.
You know what? I really should have put my golden rule number 1 is trust but verify.
That's coming up for me. So
I'll let you have that one.
Right.
You can have that. You can have that realm. So, so on this video is a nurse that posted this Facebook reel, and I love Facebook reels. I get made fun of by my girlfriend all the time. She says that I'm old because I won't watch TikTok anymore and watch Facebook reels because that's the old person thing to do.
Gotcha.
Even though she's older than me. So,
yeah.
Yep. So she calls me an old person for watching Facebook reels. But so there was this nurse that posted this video, and it's kind of like one of those ones, like it shows them like depicting like as a FTO nurse or a precepting nurse with their new hire. And the caption said, "I put the chest tube directly into wall suction. Is that right?" And it's like, then it breaks to them, like running to the room type thing. Like they completely messed up and all of these things, like the world is going to end, and like because this person hooked up a chest tube directly to wall suction. And I'm sitting there thinking to myself, like, are we doing something wrong? Because like
I do that all the time.
Like we do that all the time. Like we hook up chest tubes to wall suction frequently. Yes, it's regulated wall suction, which every hospital, I'm sure, per some form of regulation has to have a regulated wall suction. Yep. It just can't be at 300 all the time. Even our ambulance suctions have a dial to turn up the suction pressure. So the comments that came out of that are just like ridiculous, though, man. Like, maybe we'll post a link to this Facebook reel because I did myself the favor of saving it this time. Some of them are like, maybe if nursing schools taught skills and machines a bit more instead of care plan, or in care plans a little bit less, just saying, like, maybe, like we teach certain aspects of this because like not every system is going to use an atrium. They don't all have to go to water seal. Yep. Or like let's see, some of these other ones. Nurses have been eating their young for too long. How about a little mentoring and support, which I loved that. I loved that. I mean, like, and that got 74 likes and little hearts to it. Like, people were agreeing with that.
I agree as well.
Yeah.
With that. I don't, again, we'll get to all section.
Yeah.
But keep going.
Okay. Now, to be fair, they do not teach nurses enough about chest tubes. Clamp, don't clamp, blah, blah, blah. And then they change up those sucker up looking things for the air leak and how to set them up and bubbles, no bubbles. It honestly, 25 years ICU nurse, maybe go back to the days where they just used bottles. You know, that's still a water seal. Still don't have to have it. Like,
yep.
You know, we're going to get into some data and some of these things. Like, it's crazy to me to think that this blew up when people didn't just make a simple search of like, do you have to have a water seal or an atrium for a chest tube?
Correct.
Like, talk them through, what do we do? Like,
well, so obviously for EMS and for us, it's going to be a little different.
Yeah.
Because I don't carry a nice big water seal.
No.
Right.
It's weight.
Yeah. And it's something that you're going to want to keep sterile and keep clean. And there's no room for that in the helicopter. Right. And when we're doing chest tubes in the field, like the fact that we even get suction sometimes is, I mean, that's great. If we even get it, that's a perk.
Yeah.
You know? So correct. No, we don't have to go to a water seal, especially right away.
Yeah. Right.
Eventually, yes, that person needs to be on a water seal. If it's a long term in the ICU, for sure, they're going to be on that water seal, right? And that is important. That's going to give us a lot of good information about how that chest tube is doing.
Yeah.
If it's sealed properly, if it's leaking, if
they're reinflating appropriately, you can set their centimeters of water of negative pressure. There's a lot of perks to the water seal.
Absolutely.
But do you know how many hours you can have a chest tube hooked up to wall suction before you are supposed to put a water seal on?
Is it 48?
Yeah. 12 to 48 hours.
Yeah.
Before you even really need to consider a water seal. And this was in a pediatric study.
Gotcha.
Like, I mean, like, 12 to 48 hours. It's mind-boggling to me that a simple little search or like a simple fun video like this, I mean, like, I can't say that maybe they didn't search it or something like that, just blew up into this thing and it just made me sit there go like, like, I wonder if our Heimlich valve's just enough.
Yeah. Right. And that's something, that is something that you should have.
Yeah. You do need to have your
Heimlich valve on there.
Yeah. And for those of you that don't know what a Heimlich valve is, because they don't typically go on with a water seal, right? It's a one-way kind of duckbill looking valve that's encased in plastic that it basically acts like a one-way valve. Yep. Lets air out, doesn't let it back in. So it allows for blood drainage, air drainage, hooks directly up to our, I mean, it's built to hook directly to our suction canister. Yes. Like, it's built for that.
Yes, it is.
And like, it just is, I think this really got to me more or less, like, for some of the initial comments of like,
I got you.
Maybe we shouldn't eat our young and be appropriately training them. Like, I feel that 100%. I mean, there's a point where we need to eat the young
a little bit.
Like, but I mean, like, we shouldn't be terming it that. We should be mentoring them in like I don't know how to put this, like it's not a stern way, but like, you want to make sure that they're doing it right.
Totally.
Like, so we want to, I mean, like, reduce error, but also allow them to learn at their own capacity. And, there's a lot of people on here that were just, A, agreeing with it, which is not true, and B, just like, really getting after like how we need to change some of these processes, which is a topic for another day. The big thing that I want to take out of this is we want to talk about, why chest tubes, why they're important in our realm. I mean, you're not going to see a lot of them on ground ambulances, but as flight paramedics, like, having a chest tube is a pretty big deal because the agency I came from, the state regulations only allowed us, even in a helicopter, to do needle thoracentesis. So
not even finger thoracotomy.
Nope. Ooh. Yep.
Which I still struggle with the concept of like finger thoracotomy over chest tube. I don't understand why that's even a thought process.
Yeah.
Because it's proven so many times that chest tube is far superior than the finger thoracotomy.
Mm-hmm.
I don't know. I feel like if you're doing a finger thoracotomy, that a chest tube's just as appropriate, because why make a hole and then just seal it back up?
Yeah. So like, coming from that side of things, I don't know if it's like extra training, extra cost, like suture kits, staples. Do we say suture versus staple, which we'll talk about a little bit, but like when we were training on finger thoracotomy, it was just like, okay, like stick your finger in, do the finger sweep, don't cut your finger. And then you're going to put your vented chest seal on. It's just like, well, like now we basically just caused a gunshot, like a sucking chest wound almost at that point. Now we're going to seal it up. And what happens if they retention? Oh, well, you got to make sure your drain's pointing down, which is a very normal thing to do. But if it's not draining or if it's not releasing that air, then you got to open it back up. Then you might have to stick your finger in. It's just like, this is kind of a pain in the ass.
Versus throwing a tube in it.
Yeah. But I don't know the understanding behind it, because there's a lot of people out there that'll say, a finger thoracotomy is just as good as a chest tube, which, I haven't put my first chest tube in yet, so I don't know what I don't know.
Fair enough.
Yeah. Trained on it a lot. Yep. Excited to put, I always hate to see people get hurt, but I'm excited to be able to provide that service to somebody at some point.
Yeah. It's it's a great thing to be able to do. And it's great to see how effective it is.
Mm-hmm.
Just did one 2 weeks ago, maybe.
Yeah, I got the first chest tube of the year.
First chest tube of the year. Suck it, Chad.
Yep. We'll have to. We'll get you a little trophy.
Thank you.
Make you feel a little bit better.
That's good. Give me one for last year too. But no, it works. It works well. As far as, I don't even know where to go with that. Let's see.
As far as the procedure goes, how do you feel like do you feel like it's a fairly easy procedure once you get it down the first couple times? Like, it's not a benign procedure. You're putting a hole in somebody's chest. That's one thing. Like, if we carried ANSEF, it'd be great if you're putting a hole in somebody's chest or penetrating trauma, give the ANSEF type thing. But it's not a benign procedure.
No, it's not. And it's something that truly does help your patient, right? Way better than just your needle thoracotomy.
Mm-hmm.
It's amazing how quick their vitals change and how much better they do when you put that chest tube in, right? When they need one. The hardest part about a chest tube is, just like with a crike, is, picking up the scalpel.
Yeah.
Right? Is, what you have to do. You've trained on it. You know how to do it. The hardest part is just actually doing it, is picking up that and making that decision. Because, I don't know, I've done a lot. But
is there a pattern we're seeing?
Personally, I've, made the cut, put the tube in, I think 4 or 5 times. I've probably been on them, helped a partner out, or, been a part of them probably 15 times.
Yeah.
Just seen a lot of them. But it's still, even on this last one, it's like, okay, just do it.
Take a breath.
Take a breath and do it.
Yeah.
Right.
Think like Nike. Just do it.
Just do it.
Not a sponsor.
Right. So if I know, I know they need one, we're just going to do it. And like I said, the hardest part is just picking up the scalpel. But no, it's amazing how much better they do. And when you pop through, and you get that rush of air, you spread and you get all that blood out, right? It's the patients do a whole lot better. And get that chest tube in, staple it up, or suture it up, depending on whatever your protocols are, what you have available. Personally, staples are great. I like stapling it, especially for speed, right? If I'm trying to get stuff going, I'll just throw a couple staples in it and keep going. There's definitely times to suture it, especially when you have somebody like, a burn patient, right? Because one of the ways we staple that hole up, you're going to put your petroleum gauze around it, just really try to keep it sealed and tape it all up. But when you have somebody who's like burnt or whatever it is, or some, they're super diaphoretic, a lot of times that tape that we put all along it just doesn't stick well.
Okay.
So making sure that you're able to suture that and keep that in place so it's not going to come out is important. So I think it's good to know how to do all the ways to secure it. I mean, we used to have a way we would secure it was what are those grip things?
I can't remember.
I don't even remember. But basically, it would go around the tube and pinch through the skin, and you just leave that clamped in place.
That sounds miserable.
It was miserable for the patient. So
yeah.
That's why we don't do it anymore. But I there might be programs that still do that. I don't know. But however you know how to secure it, just, again, make sure once that tube's in that you're keeping that secured and sealed up. So
yeah, no, I practiced suturing for the first time just this past week because, I'd never had a place where I needed to suture anything.
Gotcha.
And, you guys took everything out and taught me how to suture and, do surgical knots and all the fun things. But I was pretty blown away at the difference in the amount of secureness that the chest tube actually had with the suturing. So, I will probably be leaning towards more that way.
Yeah.
I mean, I'm sure with my first one, I'm going to be like just excited that it's done.
Yeah.
More than anything. But, just the amount, how secure it truly was really impressive to me. And because I'd been just practicing with staples on our trauma man.
Yeah.
And, it's in there. But I mean, like,
the staples,
everything's dislodgeable, right?
Yeah. And the staples really don't secure your tube.
Yeah.
It just helps kind of seal that hole and making sure you have a good seal. But if you're really wanting to secure it, then suturing's the way to go.
I mean, like where we have our patient sits up with right side of their body to the door of the aircraft, right? Like, I'd rather, if I have to put a right-sided chest tube in, have it sutured so I know it's not going to go anywhere.
Yep.
That left side, as long as we can monitor it and make sure it doesn't go anywhere, at least I think that it'd be really good that the side that's going to have the most impact by the aircraft should get a suture in it.
Yeah.
But I was also really surprised at, how not pretty it has to be for this situation.
Yeah. Yeah. We're not making it pretty. Exactly. Yeah. And the whole point with that suture is you're not, again, suturing up that cut and making it all pretty. You're putting it through it, tying a knot, wrapping it around your chest tube, throwing another suture in, tying it off, and calling it a day.
Yeah.
So.
Yeah. I'm trying to reduce that leak, but secure it at the same time.
Yep. Yeah. No, it's, we can get into the chest tube stuff pretty heavy, as far as how that goes. A couple tips and tricks. I'll just throw a couple in there right now.
Go for it.
Step number 1 is arm up. Make sure that their arm is above their head, right? Doesn't matter if you think you need to or not, if their arm's busted or not, give them a bunch of ketamine, right? And put their arm up. That's step number 1. Because if you don't, again, you want them spread out as much as you can because you want those ribs to be open so that you can actually punch through, get your finger through, and get a chest tube in there. Because when it's not, I can promise you, because I've been there and done it, when my partner's doing one on the other side, his arm's up, my arm was down, body's kind of this way, cool, get in, and now I can't get through the ribs at all because just of their position. So positioning super important. And for me, when I'm checking your landmarks are great, right? Especially on you're doing your simulations or you're training for it. Remember that there's no trauma to that.
Yeah.
To that thing, right? To that little sim man or whatever you're training on. When there's actually trauma involved, muscles get moved around, skin, everything. So it doesn't always look pretty. I've had to had a guy get shot right in his nipple, right through the nipple. And, I'm like, I was telling my partner, I'm like, I can't find my landmarks. And she's like, just follow the nipple. And so I look up and I'm like, he doesn't have a nipple.
And that's a good point because you got to remember also and where the nipple would fall anatomically correct.
Correct.
Because I got man boobs. They're not anatomically correct on me.
Right. And where that was that's part where that muscle secures too. So now that whole chest muscle's falling down and it's I'm not feeling the ribs underneath it. So for me, I'm going to, again, put that arm up and then I'm just going to put my fist right in their armpit.
Yep.
Right. So if it's on their right side, I'm going to put my left fist right into their armpit and I'm going to use my thumb for my finding my ribs and following that line down, follow that nipple line, follow where it should go, right? Remember, you can find your ribs up higher as well if you need to, if they're a little fluffy, right? So you can, just like you would do an needle thoracotomy, find your ribs, and then you can follow that down. Again, use your thumb in that armpit, so that way you know you're right in your triangle of safety, right? Because you get too low, you're going to go into a liver.
Yep.
You don't want that.
Yeah.
So
on either side. If your liver's on your left side, you got a bigger problem.
Right? You're going to go to a liver, or if you get below the diaphragm, on either side, you got problems. So making sure you're high enough up.
Yep. When you're making that cut, you going above or below the rib?
The rib? I'm going on the top of the rib. So.
Okay. Yep. Yeah, just when you're making, I mean, and the same goes with our needle decompression for those people out there. Yeah. You always want to guide over the top of the rib because you're going to avoid the intercostal arteries. So
and the goodness, arteries, veins, and
nerves.
Holy shit!
Yes.
Those
things.
So back to that. Yes, avoid those arteries and nerves as well. All those are going to run on the bottom of the ribs. So
yep. And then really the procedure's not overly complex.
No.
I mean, you want to talk them through just, like the initial, nuts and bolts of the procedures, and
again, find your arm up, find your landmarks, use that fist, find that triangle of safety, right? Use your thumb, figure out where it is. You're going to get your stuff out, ready to go. You can even mark that spot if you need to begin with, right? And then lay everything out, get your gloves on, have somebody open the package, you grab your stuff, keep it sterile, right? Sterile as much as you can.
Yeah.
I mean, the last one I did was literally on the side of the road in a little burrow pit, right?
Yep.
But I mean, I had a sheet, laid it out, like, this is my sterile area, everybody. Do not touch it.
Yeah.
Like, you can touch this packaging, do not touch any of the devices in here.
Yeah.
Right? So I'm going to keep that sterile, right? We're going to get our number 10 scalpel out. Make sure you have a big enough scalpel, right? And you're going to start dissecting down until you get down to that, to the ribs there, and to the
pleura.
Thank you. You're going to start dissecting down until you get down to the pleura, and you can feel that, right? Once you get in there, use your finger, figure out where you're at, making sure, again, you're still on top of that rib, right? And you're going to get down to that pleura. Then you're going to take your blunt dissection, pop through, right? It's forceful, right? Some of the chest tubes come with a super pointy thing on it. We don't use that. A lot of places don't use that. I wouldn't recommend it because it is very sharp, and if you punch too far through, you can go into the lung and now cause more bleeding and more problems. So we don't want to do that. Use your blunt dissection, pop through. You're going to spread. When you spread, when you just open that up, what happens is it just goes deeper in, and you're not actually making that hole any bigger.
Yeah.
So spread as you come out, and you're going to feel it tear and rip a little bit, right? And you're going to feel that open up, and that's when you're going to get a whole bunch of blood coming out, which is a good thing.
Yep.
Okay. And then after that, you're going to stick your finger in the hole, sterile glove, right? You should be sterile up at this point. Anyway, stick your finger in, make sure you're in the right place, feeling lung, make sure you're not feeling the diaphragm above your finger, stuff like that. And then you're going to put your chest tube in. If I'm on the right side, I'm going to point towards the left clavicle. I'm going to go up. Just depends on the side of the patient, but typically I advance in. If I feel it hit something, I'm going to come back a little bit, right? Make sure I'm not too high or my tube's not bent over. And then, that's where I'm going to secure it. So,
it's not the most complex. I was really overthinking it when I first was trying to learn it. And it's really not as bad as once thought it was going to be.
Yeah. And remember that tube as well needs to be kept sterile. Right. So typically what I do with that tube is I'm going to grab the end of it with my same blunt dissection.
Yeah. Your Kelly
clamps. My
Carmalts
Kelly clamps, Carmalts. And I'm going to grab the end of that tube. I'm going to have my finger in there, and I'm going to push it up to my finger, push that through and take it off.
Yeah.
And then continue to feed that through. And then same thing with your, what's the little device we talked about? I'm brain farting bad today. Sorry.
The
one-way valve thing.
Heimlich valve?
Mm-hmm.
Yes.
Yeah, and then just remember that your Heimlich valve needs to be kept sterile as well. So connect that to the end of your tube, and then you're going to connect suction up to that. But try to keep all of that as sterile as possible. Right. The last thing you want to hear is your patient got empyema because it was dirty.
Yeah.
Right. All the stuff, any kind of surgical procedure we do in the field is going to be dirty, but keep it as clean as possible. And then, hook that up to wall suction.
Yes.
Right?
We came full circle back to wall suction.
Full circle back to wall suction. Hook that up to wall suction. Turn it on.
Let her rip, tater chip.
That's right. And hopefully you're going to get some blood out. Right. And then pay attention to how much you're getting out. Right. If that suction canister is just filling up, pay attention.
Yep.
So
going to start looking at maybe needing to add blood.
Yep. Add more blood because you probably should be already having some.
Yep.
But we don't want to sit there and just
suck them dry.
Suck them dry for sure.
We're not vampires.
You can hold a lot of blood in your chest cavity.
Yes. So. You can. Fun fact about that is you can hold your entire circulating volume of what would keep you alive in your chest without promoting any signs of jugular venous distension like you would see in a pneumothorax or anything like that. Normally, those patients are going to get flat neck veins. Yeah. They're going to get super tachycardic. They're going to get super hypotensive. And, it's really hard to identify that because, you can hold pretty much your entire circulating volume in your chest cavity.
Yeah.
And
yes, you can. And we shouldn't be waiting for those signs as well to do those procedures, right? I mean, if you have any kind of tension physiology, right, and you've got the mechanism, you feel broken ribs, you feel air, stuff like that, get it done. So put that.
I love feeling subcutaneous air.
Oh, I do too.
It's so good. And one of the things too is like how much blood do you feel like is a lot, or when you want to start, like thinking of transfusion once you get into that hemopneumo, like if they instantly put out 500, 600 mLs, like are you going straight to your blood, or are you going?
Absolutely. Yeah, I'm going straight to blood on those. If I know, especially trauma, if I'm going to volume resuscitate, I know that we need volume resuscitation because they're bleeding. Yeah. I'm going to blood because I have blood.
100%.
So that's the benefit of it, right? If not, then you better get that fluid on as well. And when I put in, we're again amazingly blessed. We have whole blood. It works so good. Yeah. It is insane how quick it turns people around.
Mind blowing.
And so, I'm putting in all our whole bloods are about 500 mLs, right? Which your pack cell is around 300, 330. But that whole blood, I'm putting 500 in, and I'm probably going to be putting 500 of NS behind it as well. Yeah. And then if not, starting another unit of whole blood if I have it. So
perfect. Cool, man. Yeah.
And as far as too much, I don't know.
I think just blood out needs to be put back in. So I'm in that same kind of world. I mean, like it kind of comes down to like, I think about it as like the postpartum hemorrhage. Like we had this conversation the other day with a couple people of like, they laid them flat, 600 mLs of blood comes rushing out of the vaginal canal. It's just like, is that enough to, warrant a transfusion?
Yes.
I mean, like out of hospital, we don't know. So always err on that safe side, right? In hospital where we can do repeat H&H and things like that, check clotting factors and all that other stuff, it might be a little bit different. Yeah. So that's when you start like trending more towards vital signs. But I'm under the whole game now since we have this amazing ability that if a mass amount of blood is coming out, I'm going to be replacing with blood, which is so nice.
Yeah. And if I have that high index of suspicion of like they need volume, then we're going to give it. So same thing with, don't forget your TXA
and your calcium,
all
the fun things,
all the good stuff.
So, well, cool, man. We didn't really tell anybody about our, to go and, check out our books. So
no, we didn't.
Don't forget.
Go ahead.
Don't forget, this is kind of a good point to start tailoring down is we have this very cool book. Isaac and I worked our butts off on this. It is over 240 pages of blissful knowledge. We've gotten a lot of really good feedback on it, and I'm really happy with it. And, in a couple years, we'll do another rendition of it. And we're we're always looking for more projects and things to do. So not like we don't have enough on our plate already, but find a book, find a course. We got a lot of people going through the course right now. It seems to be doing fairly good. Went through and fixed a couple things from some provider feedback or some student feedback, which is always really good. So really good. Glad to start getting some of that feedback, and are really appreciative of the people that reach out and talk to us a little bit. So don't forget about the flight logs and all the other things that we have. Just come to the website, standbyfortones.com, spforT.com, come to the Facebook page, whatever.
Don't forget the free app.
Oh yes, the free app
on the App Store. Sam's been working a lot on that. Yep. So lots of new stuff.
Yeah, we pay a lot of money to keep that going, and it's free, so you're welcome.
Yes, you are.
Yeah. But yeah, man, I don't know if we got anything else tonight.
No, I think we can definitely start wrapping this one up and call it a day. We appreciate you guys listening and look forward to seeing you in the next one.
As always,
stand by for tones.